Good day to all students. So today in this topic we are going to see hip joint in detail. So the hip joint is also called as coxal joint. So these are the hip bones, okay, and this is what is the femur. So this is the hip joint, which is also called as coxal joint, a joint between the acetabulum of the hip bone with the head of the femur, which is also a multi-axial type of joint. So this hip joint is the largest multi-axial ball and socket type of synovial joint. So when a question on hip joint is being asked, it has to be written under following headings: the type of the joint, the articular surfaces, the ligaments, the relations of the joint, the bursae around the joint, arterial supply to the joint, nerve supply of the joint, and movements and applied aspect. And if there is any characteristic feature of the joint, also should be added. Here it is the stability of the joint, which is a characteristic feature which we are going to see. So now the hip joint, as we said, is the largest ball and socket type of synovial joint, which is a multi-axial type as well. So when we come to the type of the hip joint, it is a multi-axial synovial joint of ball and socket variety. Now, what are the main functions of the joint? The most important being supporting the body weight during standing, and it also transmits the forces generated by the movement of the trunk, that is walking, running, jumping and all that. So if you look here into the picture, these are all the lumbar vertebrae, this is the sacrum, and this is what is the hip bone and the femur. Here it is the hip joint, which is formed between the acetabulum of the hip bone and head of the femur. This joint is called as sacroiliac joint. So this is the ilium part of the hip bone, which is articulating with the sacrum. So it is a sacroiliac joint. So the weight, here you can see the weight of a person, the total body weight, is transmitted equally between both the limbs. So the weight, it transmits through the hip joint. That is the reason the hip joint bears the whole body weight during standing posture. Suppose if a person is about 50 kgs, each hip joint gets 25 kgs part of the body weight that is transmitted from the axial skeleton to the lower limb to support a person during standing. And it is multi-axial, so it permits movements because of the long and narrow neck. Here you can see, which acts as a strut and makes an angle with the shaft of the femur, which is called as neck shaft angle, which is very important to determine the range of movements. So the range of movements is restricted because of the neck shaft angle in the hip joint, unlike in the shoulder joint. That is the reason the range of movement is more in the shoulder joint when compared to the hip joint because of the neck shaft angle. So the role of movement is determined by the neck shaft angle. So this neck shaft angle approximately in adults is about 125 degrees and in child it is about 160 degrees. So yeah, this is another picture where you can see clearly the opened up picture of the hip joint, where you can see clearly the acetabular fossa, the acetabulum of the hip bone, and this is what is the head of the femur. So this head of the femur articulates with the acetabular cavity to form the hip joint. So coming to the bones forming the joint are the articular surfaces. They are the head of the femur, which articulates with the horseshoe shaped acetabulum of the hip bone to form the hip joint. Now coming to the head of the femur. So this head of the femur, it is about 2/3 of the sphere. The head of the femur is articular except at the fovea, or a pit, you can call it as fovea capitis, where the ligamentum teres ligament is attached. So whole of the head of the femur, which is forming 2/3 of the sphere, is articular except at the fovea capitis, where it has its attachment to the ligamentum teres. And the articular surface is covered by the hyaline cartilage, which is called as the articular cartilage also, which is thick in the center and thin towards the periphery. And this cartilage, it extends over a small area onto the anterior surface of neck of the femur. And then coming to a cup-shaped structure, the socket, the acetabulum. So this acetabulum, it presents three features. It is a horseshoe-shaped lunate surface, the acetabular notch, and acetabular fossa. So all these three put together, they form acetabulum. So the socket of the ball and socket type of the joint is formed by this acetabulum of the hip bone. This acetabulum is the place where the ilium, ischium, and the pubis meet, and they are separated by a triradiate cartilage, which usually starts its ossification at or after 12 years and is completed by 20th year. So this acetabulum is the meeting point for the three parts of the hip bone, the ilium, the ischium, and the pubis, and are separated by a triradiate cartilage. So of all these features of the acetabulum, only the lunate surface of the acetabulum is articular and is covered by the articular cartilage. The acetabular fossa here, it's filled with fat. So this part of the acetabulum is non-articular, and the acetabular notch is bridged by the transverse acetabular ligament. So that also becomes non-articular. And the rim of the acetabulum has its attachment to a fibrocartilaginous structure, the labrum, which will deepen the socket of the acetabulum. So you can see a gap between the bony notch and the transverse acetabular ligament, through which there will be passage of the acetabular branches of the obturator and medial circumflex femoral vessels, which supply, you can see here, they are passing out here, which supply the head of the femur and the acetabular fossa. Then posterior-superior here to the acetabulum, there is a shelf-like buttress and standing, that is shelf-like support. So in the posterior-superior part of the articular surface, somewhere here. So there is a strong buttress-like thing that is formed, which usually develops during the second month of the intrauterine life. If there is any failure of developing this shelf-like strong area, the buttress, shelf-like buttress here in the second intrauterine life, through which the body weight is transmitted, there can be congenital dislocation of the hip joint. That is a point to be remembered. So here in the acetabular fossa, as we said, that it is filled with fat, which is called as acetabular fat or the Haversian fat. And this fat is covered by the synovial membrane. So this acetabular fat is intracapsular and extrasynovial. There are few structures even in the knee joint which are intracapsular and extrasynovial. So here a point to be remembered is the Haversian pad of fat or the acetabular fat is intracapsular and extrasynovial, and the fat is in liquid condition at body temperature. So whenever there is increased movement of the joint, this fat gets filled up in the vacuum space that is created there. So that's how the fat function is being maintained. So this is what is the representation of ball and socket type of joint, where there can be various movements that can take place in this type of the synovial joint. Now let's see the ligaments of the hip joint. There are extracapsular ligaments and intracapsular ligament. So there are 3 extracapsular ligaments and 3 intracapsular ligaments. So the extracapsular ligaments are the iliofemoral ligament between the femur and the ilium part of the hip bone, the pubofemoral ligament, that is the pubis part of the hip bone to the femur, and ischio-femoral ligament, we can see on the other side, which is attached to the ischium part of the hip bone to the femur. So these three, the iliofemoral ligament, the pubofemoral ligament, and the ischio-femoral ligament, are the three extracapsular ligaments which are attached to the femur to the three different parts of the hip bone, the ilium, ischium, and pubis, of which the iliofemoral ligament is a Y-shaped ligament and is anterior to the joint, and it limits the extension movement. The pubofemoral ligament is antero-inferior to the joint, and this ligament limits the abduction and the lateral rotation movements of the joint. And the ischio-femoral ligament is on the posterior aspect of the joint, and this ligament limits the medial rotation of the joint. Now coming to the other three intracapsular ligaments, which are the acetabular labrum, which is attached to the rim of the acetabulum, and the transverse acetabular ligament, and the ligament of the femoral head, or the ligamentum capitis. So this acetabular labrum, it is a fibrocartilaginous ring which will increase the depth of the acetabulum to retain the head tightly into the socket. The transverse acetabular ligament, it bridges the acetabular notch, converting it into a foramen through which the acetabular vessels can pass into the joint. And the ligament of the femoral head, or the ligament capitis, it carries the blood vessels to the head of the femur. So these are the 6 ligaments, of which 3 are extracapsular and 3 are intracapsular. So now let us see them in detail. Here in this diagram you can clearly see this is the iliofemoral ligament, which is Y-shaped ligament, which is attached to the ilium part of the hip bone to the femur and is anterior. This is the pubofemoral ligament, which is attached to the pubic part of the hip bone to the femur, and this is antero-inferior. And this is the ischio-femoral ligament, where it is attached to the ischium part of the hip bone to the femur and is posterior to the joint. These are the extracapsular ligaments. Coming to the intracapsular ligaments, you can very clearly see the transverse acetabular ligament is this, bridging the acetabular notch, converting it to the foramen through which the acetabular vessels can pass through into the joint. And the rim of the acetabulum, the glistening thing what you can see here, is the acetabular labrum, which helps in deepening the socket, the acetabular socket. And this is the ligament of head of the femur, or the round ligament, or ligamentum capitis. So this carries the blood vessels to supply the head of the femur. So these are the intracapsular ligaments. So the articular capsule. So the capsule of the joint, it envelops the whole joint, and the fibers of the capsule, they become spirally arranged and become taut during extension, and they get unspiraled and relaxed during flexion. when you come to the attachments of the capsule, proximally it is attached close to the acetabulum, little away from the rim of the acetabulum, about 5 to 6 centimeters above the acetabular margin. Here you can see this is the acetabulum. Just above the margin of the acetabulum, it is attached proximally, and to the margins of the transverse acetabular ligament, because this transverse acetabular ligament is converting the acetabular notch into a proper cup-shaped structure. It is bridging the acetabular notch. So this capsule is attached to the margins of the acetabulum above here and to the acetabular, transverse acetabular ligament as well. And distally, the capsule is attached anteriorly to the intertrochanteric line, and here posteriorly it is about 1 centimeter medial to the intertrochanteric crest, where the capsule is related little close to the greater trochanter and away and above from the lesser trochanter. So here you can see in the anterior view it is attached to the intertrochanteric line, and here you can see it is attached on to the neck of the femur about 1 centimeter medial to the intertrochanteric crest. And the fibers of the capsule here from the intertrochanteric line, few fibers, they are reflected upwards and medially along the neck. Here you can see along the neck, this is the intertrochanteric line. So from the intertrochanteric line, few of the fibers of the capsule, they are reflected medially onto the neck, which are beneath the synovial membrane. They are called as retinacular fibers. So what are these retinacular fibers and what is the importance? They are the longitudinal fibers on the anterior surface of the neck. So this capsule, it has two types of fibers, inner circular fibers and outer longitudinal fibers. So these outer longitudinal fibers are reflecting from the intertrochanteric line on the anterior surface of the neck of the femur as retinacular fibers. And these support the arteries that are running towards the head, which are the retinacular arteries, which are the branches from the medial circumflex humeral artery. And as the capsule also blends with the other surrounding ligaments, it becomes extremely strong and providing relatively a very stable joint. Now coming to a little more of articular capsule. This capsule is thicker anterosuperiorly, where the maximal stress occurs, particularly in standing position. Posterior-inferiorly, it is thin and loosely attached. So the capsule, the fibers, they are of two types. The inner circular fibers, this is the cross section we are seeing. So this is the circular fibers, these longitudinal lines, they form the longitudinal fibers, they represent. So they have inner circular fibers and outer longitudinal fibers. The inner circular fibers, they form collar around the femoral neck. And spiral fibers of ischiofemoral ligament, they are continuous with the inner circular fibers, which are called as zona orbicularis. So these zona orbicularis, or the circular fibers, they are directly not attached to the bone. Via the ischiofemoral ligament, they are attached to the femur. And the outer longitudinal fibers are reflected, as we said, along the neck from the intertrochanteric line to form the retinacula to convey the blood vessels. So the inferomedial part is the weakest part of the capsule. So this part of the capsule will get stretched during abduction. And when the limb is hyperabducted, the femoral head can get dislocated, tearing the capsule. So this is what is all about the articular capsule, or the capsule of hip joint. So the synovial membrane. The synovial membrane is a very thin sheet of tissue that lines the inner surface of any of the capsules of the synovial joints and the tendon sheaths which are there within the capsule, that is the capsule of the joint. And the outer surface of the synovial membrane, here it is represented in red color. This is synovial membrane. Here you can see it is in green color. Okay. Yeah. So the outer surface of the synovial membrane is in relation to the fibrous capsule, and the inside of the synovial membrane is related to the synovial fluid. So the inner surface of the synovial membrane has microphage like synovial cells, which are called as fibroblast like synoviocytes, and they are of two types, type A and type B. The type A cells, both these type A, type B cells, they are found on the inner surface of the synovial membrane. So these type A cells, they maintain the synovial fluid, and type B cells, they produce the synovial fluid. And this synovial membrane, it lines all parts within the joint except the articular surfaces. So it lines the inner surface of the capsule. It covers the part of the neck as far as the head of the femur. Articular surface, till the articular surface, it is lining the neck of the femur. That is the reason we said that the reticular fibers are behind the synovial membrane. Okay, it also covers the acetabular labrum, both inner and outer surfaces of the acetabular labrum. And then the ligament of the head of the femur is also covered by the synovial membrane, and the transverse acetabular ligament is also covered by the synovial membrane. Here you can very clearly see it is all, whatever is there in green color is the synovial membrane. Okay, and it also covers the fat in the acetabular fossa. We said that fat 2 is intracapsular but extra synovial. Occasionally what happens is the synovial membrane may protrude between the iliofemoral and the tubofemoral ligaments as a subpsoas bursa, which may become continuous with the psoas bursa, which is found around the hip joint beneath the psoas major muscle. Okay, so this is what is about the synovial membrane. In short, if we say that the synovial membrane, it lines the inner aspect of the fibrous capsule, intracapsular portion of the neck of the femur, the acetabular labrum here, and the ligamentum teres and the fat in the acetabular fossa. Acetabular labrum. So this is a fibrocartilaginous rim attached to the margin of the acetabulum. And since it being a fibrocartilaginous structure, it is made up of type 1 collagen. So you can see this violet color, the dark violet color, that is the acetabular labrum. So this labrum, which is attached to the rim of the acetabulum, not only deepens the acetabulum, the socket of the acetabulum, but it grasps the head of the femur tightly into the socket. So when the fibrous capsule is disconnected due to some injury, still this labrum can hold the head of the femur in its position. So this lines the acetabular socket attached to the bony rim of the acetabulum. It is wider and thinner anteriorly and thick posteriorly. And this labrum, as we said, is triangular in cross section. So this dark one is the labrum. This is the acetabulum bone. So it has three surfaces: the internal articular surface, the external articular surface, which is vascular because it is related to the capsule, and inner surface is avascular because it is related to the synovial fluid, and the base, this one, the base, which is attached to the acetabular bone and also to the ligaments, the transverse acetabular ligament, this one. There are a few functions of this acetabular labrum, where it is the joint stability. As it deepens the socket, it increases the surface area of the joint, allowing a wider area of force distribution. It acts as a shock absorber. As it is attached to the rim of the acetabulum, it keeps the synovial fluid in contact with the articular cartilages of the acetabulum as well as the head of the femur, and it also distributes the pressure equally by not allowing the synovial fluid to seep out of the joint capsule of the joint cavity. And when there is a weight bearing during standing, the cartilage receives equally distributed weight bearing, so that the stress on the cartilage is much reduced. And since it deepens the acetabular cavity, the socket. The decreased contact stress between the acetabular and the femoral cartilage is also there. Iliofemoral ligament, which is also called as ligament of Bigelow. It is one of the strongest ligaments. It strengthens the fibrous capsule anteriorly as it blends intimately with the fibrous capsule. So this is the iliofemoral ligament, which is triangle in shape and is inverted Y shape. This is the stem of the iliofemoral ligament and this is the base. So this is the apex or the stem. And this iliofemoral ligament, it is anterior to the hip joint, which blends with the capsule and strengthening the capsule anteriorly. Coming to the attachments, its apex or the stem, it is attached to the anterior inferior iliac spine and its base is attached to the intertrochanteric line. The base here gets diverged into medial and lateral bands. The medial band, being vertical, is attached to the lower part of the intertrochanteric line, and the lateral part or the lateral band is oblique and is attached to the tubercle in the upper part of the intertrochanteric line. You can see it very clearly over here. So the lateral band or the oblique band, which is placed obliquely, is attached to the tubercle over the upper part of the intertrochanteric line. The intermediate stratum here, the central portion, is very thin, and at times, usually this thin portion of the ligament is pierced by the ascending branch of the lateral circumflex femoral artery. So we can say that this ligament consists of three parts: the lateral thick band with oblique fibers attached to the tubercle over the intertrochanteric line, the medial thick band which has vertical fibers and is attached to the lower part of the intertrochanteric line, and the central thin portion which is usually pierced by the ascending branch of the lateral circumflex femoral artery. So in erect posture, the line of gravity passes slightly behind the head of the femurs. So there is a tendency of the backward tilting of the pelvis. So the strong iliofemoral ligament, it prevents the trunk from falling backward in standing posture. And the tensed fibers of the ligament also prevent the excessive extension of the hip joint. For this ligament to get torn, it needs about 250 to 700 lb. So this is a rarely torn ligament in the dislocations of the hip joint. Pubofemoral ligament. This is pubofemoral ligament. So pubofemoral ligament. The pubofemoral ligament also is a triangular shaped ligament with base above and apex below. So this is the pubofemoral ligament. This is present infero-medial to the hip joint and supports the joint inferiorly. The base of the pubofemoral ligament is attached to the iliopubic eminence, the superior pubic ramus, and the obturator crest. Inferiorly, it blends with the antero-inferior part of the capsule and to the medial band of the iliofemoral ligament. The pubofemoral ligament prevents the excessive abduction and extension. Occasionally, the space between the iliofemoral ligament and pubofemoral ligament, the synovial membrane may protrude as psoas bursa.